Of 41 people, 20 of them, we sent out reports suggesting that they change their prescription plan. Not the pharmacy, but the prescription plan. So we figure out if you're a married couple, that means the husband or the wife, one or the other, on average, got a notice saying, yeah, you probably want to change your prescription plan. What we're doing, everything we can do is to prevent people from having to change their pharmacy, because transferring the prescriptions, that becomes a little tedious. Sometimes things get all messed up in the process. They shouldn't, but they do. And if you really like going to your pharmacy, that's a good thing. If you don't, then let us know, and we can certainly look at all the plans available for a different set of preferred pharmacies. Many times they overlap. But back to the numbers. Of the 41 people that we've done reports for, 20 of them we made recommendations to change. On average, every one of those 20 people could save probably about $803 over the course of the year. That's between co-pays and premiums and so forth. Plan to plan. Same pharmacy, same meds, same doc, just change the insurance company and save $800. That's an average. Some are lower, some are higher. And don't forget, there's 21 people that we said just stay the course, stay with the plan. Now, that savings also is relative. Even though we're saying $803, what that means is if you stayed with the plan you currently have been in 2021, know that all their numbers will change. Their premiums might change, their co-pays and so forth. So if you stayed that course, your number was going to be, on average, $800 higher than this other plan. Now, in all fairness, it could be that you paid a lot less for that in 2021. But remember, everything changes. So it's a difference. So savings are based on staying with what you had in 2021 at its new numbers, new costs, new co-pays. That's a number. But if you go to this other plan, it's $800 less. So it's kind of like a moving window. Doesn't mean they're saving $800 from last year. It means they're saving $800 from what it would be if they made no changes. So I think for that reason, it really behooves everybody to spend some time looking and seeing what's involved. What's involved with, let's see. All right. Okay, so I don't think I can get rid of this. When I do, I can't advance the slide, so please bear with me. So what are we going to do today? We're going to talk a little short history, real short, about the history of Medicare Part D. Interesting plan, but it's the newest part of all of Medicare. A and B date way back. The whole idea of Medicare dates way back, but Part D is a relatively recent phenomenon. We're going to talk about some of the trends that we're seeing in Medicare Part D this year, the changes that are occurring. What do you want to do during open enrollment? What action should you take so we can look at your options and look at what it is, including filling out the open enrollment medication list that Laurel provides to you to fill out. There are some changes with that this year that we're experimenting with. One of them is, in the past, we'd fill out the report, do all this hard copy, put it in an envelope. Laurel would call each of you that it's ready. You'd come, you'd pick it up, go home with that information. This year, what we're trying to do is email that report to you. So if we've got your email on that form you filled out, then we're sending it directly to you. If you get it, it would be great if you could just respond back with "got it" or something so we can check off. It is email. Once again, I never really know that everything makes it where it's supposed to go. So just let us know, got it. I'm going to talk about how to read and understand what that report's telling you, what you want to do, what you don't want to do. If there's time, I'm going to walk you through the paper we passed out, which is an actual case study. So you're going to get this report that we're going to send back to you, but there's a lot of stuff there. And some is important, some really isn't, but I can't change it. It's the government's tool that we print the report from. But I can walk you through and you can circle the things you're going to want to look at that means something on your own report. And the last thing, which my guess is we'll never get to, but it's an important thing to be aware of. I mentioned the government's tool. They call it Medicare Plan Finder. One of the things the government has done exceptionally right is they've created an online decision support tool. And any one of us can go on and sign up for an account. It's in what we call mymedicare.gov, that website, and you can set up your account. It's free, but it loads all your data in the cloud. So what happens is you load all your meds in there, you update your meds, it takes that med list of yours, it knows what plan you're on now, It looks at all 21 plans that are going to be available in 2022. It figures out like a cash register. Your meds on plan 1, this is what it's going to cost you between premiums, copays, deductibles, etc. Plan 2, this is what it's going to cost you. And then it takes each one of those results and it puts them in order of what's the least expensive up to the most expensive. So this isn't rocket science, but there's a lot of heavy-duty math involved. And I don't know that I'd ever be able to figure it out, let alone figure it out this year for everybody, what it would cost you with all your options. But that's an appropriate way to look at what your options are. So the tool does that for us. And it produces a report. So when you pass in those forms with your meds on it and your information, two things are happening. One is for each and every one of you that submit that, first I make sure that you've got an account loaded up in the cloud under my Medicare.gov site. If you don't, we create one for you, and we provide you your username and password so you could go back on there as well as I could and look up all your information. The second thing that we do is we take and update that profile with your current meds based on what you tell us you're taking, and your preferred pharmacy based on what you tell us you'd like to do. And then we run that analysis. It spits out a report that says, for this person, given all their considerations, this plan is the least expensive, this is the most expensive, and this is how all 21 of them line up. And then I physically look at the least expensive one and work backwards. Does it look like it meets all of the things that you've asked about? And if so, bingo, that's the one. Produce a report that's included in the stuff we're emailing to you. And you can look and see all the details, which is that case study I mentioned, and you're holding an example of right now. So it's quite a process. It's a very time-consuming process, but it's a lot of fun. And so that's part also of what we want to just share a little bit about. But let's just see if I can move ahead here. So you remember what I said, there's the 4 parts of Medicare, the 3 parts basically. Part A, which is hospitalization. Part B is medical services, so that's the doc. Part C is if you have an Advantage plan, it combines A, B, and D. And Part D, which is really what we're talking about, is the Medicare prescription drug coverage. You remember that as you supplement your Part A and B, some people like to do it by taking their A and their B, getting a standalone Part D plan, prescription plan, and then a Medigap policy, like the common names Blue Cross MedX, Bronze, Sapphire, Core, or not Blue Cross, but the same sort of plan from Tufts or Harvard or one of the others. That's one way to do it. Now at open enrollment, the thing that we're looking at is the Part D plan. Other people like to get Advantage plans. Wraps all this stuff into one plan. But if you have an Advantage plan, know that if we look at one of these Part D plans during open enrollment, and if you were to enroll in one of these, it's going to automatically kick you out of your Advantage plan. The government will automatically kick you out. So if you've got an Advantage plan, you should let us know. There's a place in that form you check off, I've got an Advantage plan, and you'll get a contact from us saying, if that is the case, we don't want to do any analysis for you because you're going to inadvertently get kicked out of your Advantage plan as we look for a Part D plan for you, and you don't want that to happen. However, if for whatever reason you don't like your Advantage plan, you don't like the copays or the overall cost or the networks or something like that, and you want to look at getting out of that and coming over here with that MedX plan plus a Part D plan, we can talk about it, but we don't want to mess anything up because it's just as easy to take somebody that submits, and it happens, sometimes people submit this and they check off, I've got an Advantage plan, here's my list of meds. Well, if I inadvertently entered those meds and then I said, you want to change to this other Part D plan, and you did that, you're going to have a problem because you'll be kicked out of this thing, and then you're going to have to do something about your medical coverage. Does that all make sense? It only pertains to you if you've got an Advantage plan. Anyone got an Advantage plan, or you all have? You do, okay. So you shouldn't be sending us your information right now unless you want to look at reevaluating an Advantage, and that's a whole separate discussion, okay? Okay, so a little bit of history here. So the history of Medicare Part D. So it's a prescription drug benefit, and it's optional. It's optional, but in the government's funny way, even though it's optional, if you don't take one and you do someday, you're going to be penalized. So it's kind of, I use this method with my kids sometimes, but you don't have to do it, but if you don't do it, no dinner. So, that's the way it works. It was enacted by the Medicare Modernization Act in 2003, which is much later than the rest of Medicare. It actually took effect in January 1, 2006. So let's say somebody didn't sign up for a plan, didn't know about it, didn't know how to do it, decide I don't take meds, I don't want to have it. The fact is, if you did this way back when, and now you woke up in 2021 and said, I need a plan, your penalty is going to go way, way back to either 206 or whatever it was when you were eligible first for Medicare. The plans are offered through private insurance. So Medicare, A and B, actually it's the government that provides it, plus supplementation from the private sector like Blue Cross. Part D plans, the government doesn't offer anything at all. The whole plan was negotiated to be a thing with the pharma companies and the insurance companies back then. And so these plans are all private sector plans with the premiums being paid by us and the government for the plans to operate and to run. Now the plans are also reimbursed for much of the cost in rebates by manufacturers. So many of you have been on, like, say, a med, and it isn't the preferred med in that plan. They want you to be on this diuretic instead, this cardiac drug instead, this oral anti-diabetic drug instead. A lot of the background to that is they have vast teams at these insurance companies that negotiate with all the pharma companies. And some pharma companies will say, we compete in that oral anti-diabetic market with 3 other manufacturers, our drug, their drug. All drugs are not exactly the same. They're not generically equivalent, but therapeutically, I could use one or the other. We'll give you a bigger rebate than the other companies. So that insurance company, that Part D plan says, great, we're going to get a much bigger rebate. That's our preferred drug. We just have to move our patients to that drug, and that's why these things happen. It's not necessarily telling you it's a preferred drug because it's clinically better. It's because financially there's more profit to be made on the part of the pharma company and the insurance plan. Let's see, enrollees used to pay 100% of the retail cost of their drugs prior to the Affordable Care Act. The Affordable Care Act in 2010 started to close what they call the coverage gap. But up until then, you paid 100%, and those are ridiculous expensive things. But what's gone on is just the types of meds that we've got and the cost of these meds have just gone completely straight up over the last number of years. We got meds to treat things we didn't even know there were diseases for before. So that's all expensive. In fact, Medicare itself finances over 30% of all the retail prescription med spending that happens in the country every year. That's a huge number when you think about it. So 2/3 of it is funded by private citizens on employer plans and all that. But 1/3 of that is paid for by Medicare beneficiaries, and we know Medicare beneficiaries are increasing. So that number is only going to rise and rise and rise. That's why there's such concern about drug costs on the part of the government. Okay, there's 4 stages, and I'm sure you've all been bit by this in the Part D plan. There's what they call the deductible stage, the initial coverage, coverage gap or donut hole, and catastrophic coverage. So what happens? Why is this important? Because the way they figure out the price for the drug, or in your case the copay at the pharmacy, it depends on what stage you're in. And what they do is they look at how much you've spent for prescription meds, they keep this running tally, and as the number starts to climb, okay, it moves from different stages. So I'm not going to spend a lot of detail, but just to point out why the prices on the drugs different. So what happens is in January, people say, oh my God, I spent $500 this month. My Jardiance was crazily expensive this month. My Eliquis was out of sight. It was $500 this month. And that's probably right, because your plan, let's say it had a $480 deductible. That means until you've paid off the first $480, the price on that medication is the retail price. It's the real price that's paid for it. So if Jardiance costs $1,000 per bottle, until you've paid off first $480 in your plan, you're going to pay $1,000. Now, think about it, and this gets very confusing. $480, my first prescription, maybe I paid $500. Well, that took the $480, but now I've passed my deductible, and so next time I get it filled, the price structure changes. Because once I've paid off $400, let's say, in that first deductible stage, okay, and that was my deductible, let's say, and then the initial coverage is past it, now I paid $400. Now they use a whole different pricing structure. Now what they're saying is you're going to pay the copay, and the copay is $50. So January I pay $500 for my Jardiance. February I pay $50. Go figure out what happened. What happened was you paid off the deductible, you moved to the next stage, and all my other meds also had some shifting probably in what the copay is. Because until I pay off the deductible, this copay thing doesn't work on those tiers of medications that it falls into. Now, I continue to pay, and I pay, and I pay. And then somewhere out in maybe June or July, all of a sudden I go to the pharmacy, and now it's $150. What the heck's going on around here? And believe me, I would say the same thing. I do. So what happens now is once we get into this coverage gap, no longer are we paying the copay. Now we're going to pay 25% of the drug. So before, $50 had no relationship to the cost of the med. $1,000 bottle, I paid $50 for mine. Okay, I don't get it, but that's good. But now I've paid over $4,000 cumulatively come June or July for all my prescriptions. And now the price structure changes, and it goes down to charging me 25% of the list of the drug, or maybe $100. And who's paying the balance of this? Well, the insurance plan is. The insurance plan is paying the balance of that, and the manufacturers. Now, I continue to get my prescriptions, and the next month it's $150, and then it's $150 again, and maybe I hit December. And by the time I get to December, because I'm on expensive meds, I've paid like over $6,000 between what I had in copays and what the manufacturers kicked in the insurance company. Collectively, the cost for all those meds gets to $6,000. Excuse me. Now what happens is I enter the catastrophic phase, and now everything drops. No longer I'm paying 25%, now I'm paying $20. And so once again, things change in terms of the cost sharing of the med across the manufacturer, the insurance plan, and me. And that's why things look like they're pumming along, like it looks desperate. I get calls from people all the time saying, my Jardiance, I got it picked up, it's $500 this month. I can't do this next month. I can't get it in February. I can't afford this. So don't worry about it. It's going to plummet probably $40 or $50 next month. And indeed, that's what happens. And it goes kicking along, hums along until they go through the summer. And then all of a sudden they start getting to the coverage gap, and now it's gone up to $150. And they call and they say, now what's going on? The other thing that really aggravates it is the pharmacist will tell you, wow, you better check with the insurance company because your drug just went up. They didn't understand how Medicare Part D works, that was the month you moved into the next stage and all your drug prices are going to change again. So this is a very complex formula. I honestly don't know how they ever negotiated it, but they did. There's also some other things that are important terminology when it comes to Part D to be aware of, okay? No need to remember these terms. I just want to throw them out because a lot of times you'll hear people use these words, and you should know that this has got something to do with my Part D plan, and maybe what. First is benefit manager, retail or mail order pharmacies. I get a lot of questions from people when we do this part of the year or when they enter Medicare, like, I want to keep my pharmacy, or I don't like to use mail order pharmacy, or this insurance company. So let's just separate what all these things are. The insurance company is the benefit manager or pharmacy benefit manager. You will only interact with them when you pay your premiums. That's it. That's the insurance company that holds the rules. That's what we're looking at now, collectively, what the plan is. But each of these plans negotiates with retail pharmacies. CVS, Walpole Pharmacy, Wegmans, Walmart, all the different Walgreens, all the different retail pharmacies, they negotiate contracts with them. And sometimes these insurance companies find more favor with one for better rates than the other one. They call them preferred. Then sometimes when you're not preferred, the contract pricing isn't better, it's standard. In network, but standard. The worst thing is being out of network. Because out of network means that you're going to pay full list price for everything if you go to that pharmacy with that insurance plan. You sure don't want to do that. So mail order pharmacies are different than retail, as we know, because they're the ones that will send it to you in the mail, usually 90-day supplies. Now, many years ago, when mail order pharmacies first came into existence, getting a 90-day supply at low cost was new. It was different, and it was cheaper than going to the retail store. But over time, things have changed. The retail chains, the retail stores, the independent stores would like to fill 90-day supplies for you. They'll deliver them to you. Things like that, services around it, but you get to physically go someplace. You may want to, and you may not want to. Some people like to go see the pharmacist. Some will say, I never even see the pharmacist. Some will say, I don't want to stand in the line. I'd like it delivered to my home. Some will say, yeah, I like it delivered to my home, so I call Walgreens and say, I want a 90-day supply, and I want your delivery service to drop them at the house. So that takes care of that. There's so many combinations of what you can do, but keep in mind, retail pharmacies and mail order pharmacies don't have that difference in price they used to. So personally, I've used mail order, I've used retail stores, I've used the delivery to the house. I've used the drive-up delivery. I feel as a pharmacist I should try it all different ways, right? I'm not crazy about mail order only because when I've got a snag in the system, it's a little more difficult to kind of get something corrected quickly. So I like the prescriptions to be local because I can run down there if I didn't realize I'm running short, and I can get the prescription filled real fast. So those are the things you want to look at. But remember that when we look at these plans, we can keep the retail, mail order, wherever you get the pharmacy filled, stationary. We can keep it static. And then we look at the insurance plan. But the fact that we may be recommending changing an insurance plan doesn't mean we're talking about changing your pharmacy. In fact, my goal is to keep you at the same pharmacy if you like it, so you don't transfer pharmacy prescriptions, but rather look at the prescription insurance company. And remember, as I said, you're not going to deal with them other than sending a premium to them. So it's perfectly cool to change from insurance company to other. In fact, the only time of those people that we've looked at thus far that we've made suggestions, a couple of them said, I like to use mail order pharmacy. Okay, well, I've got a different plan that's going to save you money. That means you're going to have to use their mail order pharmacy. So I can't hold you at CVS. You're going to have to find out, if you make this change, what the new mail order pharmacy is and have your prescriptions transferred over there. Or easier, just have your physician send a whole new set of prescriptions there for January 1 to the new mail order pharmacy, and the insurance company will tell you who they are. Formulary. Formulary is a drug list. Formulary is when they look at all there are thousands and thousands of medications fitting into many different buckets and families and things that are equivalent and things that aren't anything like others and so forth. But the formulary is the drug list that keeps us all in order. It says that oral anti-diabetic meds that work like this, here's the 6 drugs that fit into that family, that group of cousins, if you will. And then for antihypertensives, there may be, by method of action, many different types and many different drugs. But the formulary keeps all that in order. And they use the formulary to set tiers and co-pays. So they have what they call pharmacy and therapeutics committees, P&T committees, pharmacists, nurses, and physicians that look at all these drugs and they put them in order at each of these insurance companies every year. And they reorder it based on what they feel is the best mix of meds for their patients to be receiving. And then they assign them to tiers, tier 1, tier 2, tier 3. Tier 1 may be a copay of $0 or a couple of bucks. Generally the cheap commodity generic drugs. The ones that go up a little bit higher may be a preferred type generic drug, higher copay, tier 2. Tier 3 may be starting to get to like brand name drugs. Or specific drugs. And by the time we get to like tier 5, these are specialty meds. These are the things that oral chemotherapy, for example, specialty med, other special purpose meds, expensive meds, they get up there. But for the most part, most of the meds that we all take are tier 1 and tier 2. The copays are cheap. They vary. And then this drug might be on this plan, but not on that plan, and we have to sort of ferret through all that. And that raises the question of sometimes people hear the term generic or therapeutic equivalence. So generic means aspirin is aspirin is aspirin is aspirin. Doesn't matter who makes it, it's all aspirin. Chemically, everything, it's all generically the same. Therapeutic means Tylenol and aspirin both can relieve a headache. Therapeutically, they do the same thing, but they're not chemically the same drug. So sometimes certain drugs we say there's a generic equivalent to it. Cheap, easy. Others, it's therapeutically, like inhalers. This is the inhaler you're on, and maybe it's very expensive on your plan. But in the inhaler with that category of medication, there's other ones that are therapeutically going to do the same thing for you, but they're less expensive. So physicians have to look at these things with you. You have to tell them if your inhaler is very expensive on your plan, wow, it's killing me, doc. They can look and say, all right, well, let's just switch you to this other one. It's not the same drug, but it's close enough to do the same thing, and it may be cheaper. There's a lot of trade-offs there. We mentioned the deductible, the initial, the coverage, and catastrophic phases. RX Advantage, this is a state pharmacy plan that depending on your level of income and depending on how much you spend for your prescription meds, it might be a plan that you can apply for that once you hit a certain level of spending, it will fit in and it will hold your copays at a low level and it will cap your total prescription expense for the rest of the year. But remember what I said at the beginning, this is heavily dependent upon your level of income. I don't think assets are one of the tests they look at. But it is a good program, and it's something that may benefit people, but you have to spend a lot of money on prescriptions for it to even start. So for your average person, it's not applicable. But there is a plan, and you can certainly ask us about it, and we can have you talk with the folks that run this. They're out in Worcester working for the state. Quantity limits are what they are. You know, maybe some plans say I can't give you more than 30-day supply. Others say, no, it's okay, it's a 90-day supply. Medicare Plan Finder is the tool I mentioned. An annual enrollment period is where we're at right now from until December 7th. Okay, so. Except last year. Except for, yeah. Trends in Part D. So we're seeing all sorts of changes, okay? The Part D plans, remember, you could get them as standalone plans or Medicare Advantage plans with a Part D element to it. But as I mentioned earlier, we don't mix and make. We have to be aware of that. There's two types of medications in the world, believe it or not. There are the oral things you get filled at a pharmacy and the things that you get injected at a doctor's office. The things you get injected at a doctor's office are usually billed under Part B. They have nothing to do with Part D at all. The vaccines are a little different. Shingrix, for example, for shingles, a lot of times people say, wow, this is wicked expensive. Well, that gets billed under Part D. So these insurance plans and their copays all have something to do with it. Whereas others of our vaccines get billed under Part B, and it falls into the same MedX, model that you have. There's changes in the premium for each of these plans. Some have gone up, some have come down. Some plans have disappeared, new plans have come on top. Other plans have been bought by other plans. CVS bought Aetna last year, and they're making changes in their plans. The deductible, it used to be $415 was the government set deductible maximum. It's $480 this year. So those people that had a bad January, it's going to be a worse January. Because now they can't just go to $415, now they can go to $480, and any of the plans are doing exactly that if they can. There's something for those who are taking, anyone take insulin in here? Okay.
No, I just became a diabetic, so I take metformin.
Okay. Yeah.
I'll do 3 or 4 in a day because I'm not doing it right. I get error 2, error 4.
Yeah, you're going to have to talk with the doc about that because they limit how many test strips you can get. I think it's like 30 in a month. Yeah, something like that. So it's covered under Part B. You get it filled at the pharmacy, but it's covered under Part B. But there is a limit on how much they're going to let you have if you're a type 2 diabetic, right? So, but for insulin, the point of this is the insulin is very expensive, and people that are on insulin, they go crazy with the cost of their insulin. But they started a program last year to capitate insulin so that people would spend like $30 a month every month, and that would cover all the insulin that they need. Big reason here, I think, is we saw it on the news an awful lot, the cost of insulin. You don't hear that anymore because they tried to come up with a Medicare rule to fix that. Trade-off, this is really important, trade-off between total annual cost versus cash flow. So when we run these analysis, it tells us what the total cost will be for that plan, your meds, that pharmacy, over the 2022 period. The whole year, this is what the number will be. If there's like a high deductible, meaning you probably pay more in January than a low or no deductible, and there are a few plans with $0 or $100 deductibles, what's going to happen is you're going to have a horrendous January, $500-600. I mean, potentially, I see all the time. And then it'll bow out for the rest of the year until you maybe hit the coverage gap and go back up again in the summer months. That's cash flow, right? I mean, like, wow, big expense. I can't handle that cost in January. And then, great, February through June is low, and it goes up a little bit July through the end of the year. But the cash flow there is consideration. When we look at something that over the whole year may be a little bit more expensive, a couple $100 more or something, because the deductible is lower, that smooths out the cash flow. So now January doesn't look a lot different from February, but all of those months might be a little higher than the low months were in that first plan. So one is all what it's going to cost me versus the cash flow. And this is something that we look at when we run these plans, and I may be recommending a plan to you that you could have gotten a plan that was a couple $100 more over the course of the year, but it was going to give you a terrible January. So I'm making an assumption that you would rather not get killed in January when you're buying Christmas presents, and instead smooth the cost out, albeit a little higher month by month, and at the end of the year may have spent a little bit more for that. But that's something that, we don't have the interaction as we run these analysis to tell you that, so we have to make some assumptions if it's going to work out that way. There's a decrease in the number of plans. We're from 27 last year down to 21 this year, mainly because of mergers and consolidation of some of these plans. The formularies, the tiers, the copays, all changed as well. What was a copay last year is probably different now. The tiers are different. Geez, everything seems like it's changed. And mail order, as I mentioned, is not always the least expensive way to go. So that's important because we typically think that mail order is going to be the cheapest, and it isn't necessarily. So what is important for you to do during open enrollment? First and foremost, make sure you got your eye on the ball. It's tough not to because there's signals everywhere. The commercials, Joe Namath now is on every other commercial telling you to get an Advantage plan. And, there's notices everywhere and mailings from United Healthcare like every day. So it's tough not to know it's open enrollment. But remember that it is October to December every year. If you don't make a change by that end, like December 7th, December 8th is too late, and you're going to be settled with whatever you were on, or if it converted to another plan, whatever you are on. So let me just explain how dramatic this can be. A couple years ago, we had a plan that was, I think it was like $12 or something was the monthly premium, and I got a lot of people that said, I don't take any meds, or the very inexpensive meds. We'll go with that plan. Fine, that made sense in 2020. But then they kind of disappeared. They didn't come back to see us for 2021. And now that same plan went from a premium of a couple of bucks up to $80. Yeah. And so what happened is the first bill they got in January, whether it was deducted from Social Security or they got a hard copy, was $80 for the premium. Oh my God, this used to be, 12, whatever bucks. What happened here? Well, that was correct. Those changes occurred. Had you talked to us and we looked at we would have recommended get out of that plan and go to a different plan instead. But you didn't. Time expired, and there's nothing you can do for the whole year. You're stuck paying that premium every month for that year. So what do you look in the mail for? What you should be looking for is a couple things. This is the annual notice of changes. So this is like Aetna. This came to my wife for her plan, okay? And it tells her that, look, this is the Aetna plan you were on. We're going to tell you the premium's changing, the tiers are changing, the co-pays, the preferred pharmacy's changing, your med's no longer on formula, all these things. It's a long book. You won't understand it. But it's a cue that lets you know things are changing. Don't have to understand the book. Just ask us to take a look at what you're doing. We've got these changes incorporated in that tool so we can apply those changes to your particular situation and figure out what options you should make. The other thing that's available right now that is a good thing to have is this handbook about Medicare. It's out now, the 2022 book. You just got it? Yeah, and this is, once again, it's good sleeping reading. You can put yourself to bed real fast with this thing. But it's helpful. I mean, it does explain a lot of things that are confusing so that we know what to do with them and about them. So visit the senior center as you do. See Laurel, pick up the pre-enrollment form. I'm assuming you all have done that. If not, you're doing it. Clearly and accurately put your personal information. I have got to tell you, I spend more time trying to read somebody's Medicare number, read their birth date, read their phone number, read their address, read their name, than I do doing the analysis. In many cases, I sit here looking, is that a 2 or is that a 7? Wow, there's really supposed to be 4 digits at the end of that phone number, not 2. I have seen it all. Unfortunately, whenever I say I see it all, then I see something else the next day. But, I spend more time dickering around with this than I do running an analysis for somebody. So we're getting a little frustrated with it, to be honest. And so what I'm doing is I try 2 or 3 times to open an account if we've already set up an account for somebody, because it asks you what was your My Medicare username and password. Sometimes people won't fill that in, or they'll fill in part of it, or they fill in it illegibly. And I'll go on, I'll try and open up their account, and it says, can't do it, wrong number. And I have to start interpreting, what number does that look like? What letter is that? So I spend more time, it's wasting time, honestly. So I'm doing it 3 times. If I can't get it, I'm going to send you a note saying, fix it because I can't read it. And we'll go, it's like school, but it is what it is. I apologize, but I just want to move on doing the reports. So, the other thing is sometimes people will leave that blank. They won't put a username or password. I'll go online to start creating a username and a password for them, and the government tool says, this person already has an account. They didn't put the information down. So then I use the Medicare number. I go on. It tells me if you want to say I forgot my password, I forgot my username, do this. So I do this. And I can get through most of it, but there's one last security question. They give you 5 or 6 questions to answer. And if you don't know the answer to that, like what was the first street you lived on? Where do you like to go on vacation? Where did you meet your spouse? All these things. And if you don't have that security question, you can't get in to update the account. So once again, I'm dead in the water. Reason to send it back to you, ask for your help to kind of update the information. So as clear and accurately as you can put that information is really critical. And then your meds. Put all your meds down there really clearly. The drug, the strength, once a day. I get a 90-day supply. I get a 30-day supply. Ointment. I get a 15-gram tube. It says it right on the tube. 15-gram tube. I get 1 tube a year. There's a big difference in price on some of these ointments for getting 1 tube every month and 1 tube a year. And that has everything to do with changing the recommendation we give you on the plan. So everything you can put down, I really appreciate it. The size of the package. I use inhalers. I get this inhaler. I use 1 inhaler every 2 months. Great, 6 a year. We can do the arithmetic. But that's really important, and it's never, oftentimes it's not complete, and it just slows the whole process down. Submit that report before the deadline. This time it's November 22. That's when we decided to call. Now the government has an earlier deadline for that, but we're saying 22. If I get the report by 22, it will be done in time for you to make whatever changes you need come December 7th. look for your report, whether it's coming in email or if Laura calls and says it's a hard copy. So people that didn't give us an email, there's no alternative but to leave a hard copy and have her call you to come pick it up. If you gave us an email, I'm emailing it to you. If I created a username, I'm emailing you something that says that too. Have anybody received any of those reports in the mail yet? Email? Some of you have. If you could just write back, got it. Yes, thanks. I don't care what it is. Just to acknowledge, because we want to check off it got. It's email. You know, you always kind of get nervous, like, did it really find the right email place? Because the email sometimes is legible as everything else. So it goes out, but I don't know it got there. So just letting me know you got it would be very helpful. Review your recommendation. If you have questions, ask Laurel, ask me. My number's on there. Feel free to send an email back to me, just which a lot of people have done. What did you mean by blah, 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 blah? I'll respond real quick. Email's super fast to be able to do that with you. And if you need, we'll sit and discuss it here, as we did in some cases that are more complex. There's a few different ways you can enroll in the thing. You can enroll by calling the number on the report we give you, the insurance company, and say, I want to enroll. They will disenroll you from the current one as of 1122. You can call the Medicare number. I've never done that. I don't know if that's more involved or not. And you can go online. You can go to mymedicare.gov, to the account credentials we've given you, look up your account, find that plan, and just say enroll now. It'll ask you a few questions, and you're done. So there's a lot of different ways to be able to enroll in these plans, but I think you really want to do that. And if you've got questions, certainly we want to answer those for you, but you just keep in mind that deadline. Don't let it go to the end, because it's just going to be jammed up at that point in time. So I covered a ton of stuff here, and I went real quick with my Massachusetts talking speed, right? When I was in practice at Brigham and Women's, I used to do a lot of presentations to physicians and nurses and pharmacists across the country. And I come in, I start talking, they say, wow, do you people from Massachusetts come up for air? Do you even stop between sentences? Which used to be good because I had friends that lived in Arkansas, and I said, well, I don't even know what you said, let alone what you were saying. So it's a funny thing. But I'm going to pause here and see if there's any questions y'all have that we can answer. And then, if not, I'm going to explain some of those papers that are in your laps there. Sure.
Is the monthly premium that they take out of your Social Security the same whether you're on a mail order or if you go into a pharmacy?
Oh, great question. Yes, it should be. The question was, is the premium that they take out monthly, the insurance company take out monthly, is it the same whether you're going to CVS or you're using Optum mail order pharmacy? And the answer is yeah, they're two separate things. So the premium should be the same, the one you're paying to the insurance company. The co-pays, what you pay with the mail order, or that could be different. But the premium should be the same.
Okay, because I know it's going up to over $100.
The premium.
For next year. And so far, all my co-pays on Optum are zero. But I didn't know, it just seemed like it was a big jump. And I didn't know if I went to a pharmacy and paid co-pays every 3 months, if there was going to be a difference.
Okay, so her question is, she's been paying zero for co-pays with Optum, which is the mail order pharmacy with her current plan. What if she went to CVS or Walgreens or something? You might still be paying zero. The reason for that is the zero copay comes from the tier the drug is assigned. If it's zero, it means it's probably like a tier 1 med, which means the copay is zero regardless of going to the drugstore or the mail order. Zero is zero, period. So in all likelihood, that won't change. What could change is the higher tier meds that would not be zero, where it may be $20 versus 15, or if it's in one of those higher stages, it may be 25% of what the retail pharmacy pays for it versus 25% of what Optum pays for it. They could be paying different numbers. So 25% of different numbers is a different number. But if it's just the straight copay, that should be the same regardless of where you're getting the drug filled.
But the monthly premium would be the same.
And the monthly premium would be the same. Yeah.
We send in our list of drugs to
No. When we look at the list, we're simply looking at what Part D, standalone Part D, would work best for you. However, on that front page, if you check off that you are in an Advantage plan, we don't want to look at Part D plans, because if we suggested something you signed up for, that would kick you out of your Advantage plan. On the other hand, if you're saying, should I be in the Advantage plan? Or is this the time to look at using like a Part B supplement like MedX, Sapphire, plus a standalone prescription plan? Completely separate, much more complex analysis to run. We would do that one-on-one. It would be outside of open enrollment analysis. Now, so that raises the question, but what if I have to make this change during open enrollment? So if that's your question, then you should chat with Laurel or email us, and we'll kind of look at seeing if we can find a time to set up the talk with you, because that doesn't fall into the kind of routine Part D analysis, okay? That's a different thing. We did one with somebody just this morning. She's on an Advantage plan, wondered, because her medication costs were high, whether she should instead be using MedX plus a standalone Part D plan. We ran the analysis with 2022 numbers, found out what her cost would be next year with the current Advantage plan she's in. Looked, because we know what the premiums are for the MedX plan, that's a given. I ran the analysis if she were converting to a Part D plan, just if she were, and we added the numbers together. Then we looked at them side by side, and then we make a decision. Are you better staying the course or better making the conversion? Now, there's different open enrollment periods too. You know, this open enrollment period allows you to come out of an Advantage plan and flip over to Part D, to like Sapphire or something. January to March is an Advantage open enrollment period. That's when you can move from one Advantage plan to another Advantage plan. So even though we end December, there's the first 3 months of next year is what they call the Advantage open enrollment period. I think the government is just trying to make this as flexible within means that they can for people to pick the right plan for themselves. So, but to answer your question, I would not be doing that routinely. We would do that as a separate sit-down, look through, because there's a lot of other considerations in choosing those Advantage plans. Co-pays are different, maximum out of there's 30-odd plans like that to look at. 21 Part D plans, much easier to look at. Okay.
I have a question. If you're on the AARP Medicare prescription Walgreens prescription drug plan, and you have Optum prescription.
Yep.
Can you ever go to like CVS if you have to?
So with a new prescription, yes, but if you've got maintenance prescriptions that are on file with Optum, CVS would have to transfer that prescription over to CVS to legally fill it. So, you know, that's why you can have mail order and use all your maintenance medications. Once you take every day routinely, you need to come in for mail order. But if you go to the doc with a sore throat and they give you Amox, you're not going to get it from mail order, you're going to go to CVS. Brand new prescription, one time, you go in, they fill it, you're done. You're not going to wait for it to come in the mail to do that. So there's a use for both types of pharmacies.
Do they recommend you use Walgreens, since Walgreens is in the Medicare prescription Walgreens?
So it's kind of interesting. Some of these names say Walmart in them, Walgreens in them, things like that, in the name of the plan, but it isn't necessarily the only preferred pharmacy, no.
Oh, I see.
Yeah, it's just confusing, but they like to add to the confusion.
So how do you find out the preferred pharmacy?
We're going to tell you.
Okay.
Yeah, you're going to say, look, I want to go to CVS. And if you say you like going to CVS, then I'm going to ignore everything else and only look at plans that CVS will work best for you. Some of the Shine counseling that goes on in other surrounding towns, they like to bring it down to the absolute lowest cost for you, which means you can save another $200 over the course of the year if you move all your prescriptions from Walgreens to CVS or Wegmans to Walgreens or something like that. There's a ton of different combinations you come up with. Personally, I don't think that people are, and you can tell me if you don't mind, but for a couple $100 to go through transferring all the prescriptions from one to the other becomes a little cumbersome. And at the end of the day, I don't know that people really want to do that. So I go on the default of people like just to stay with the pharmacy they told me they're using now. Let's look at any insurance company, because that's easy, but keep you at the same pharmacy you're at now. It reduces the confusion in a very confusing world.
So I could stay with CVS if I wanted to?
You can always stay with who you want to, and we just look at the plans to see what's the best plan for you.
Oh, I see.
Yeah, yeah,
Okay.
yeah. So change the insurance company. As I said, you only deal with them to get a card and to pay a premium. You're not going there to get prescriptions filled and things like that. It's way easier to change that, but keep the drugstore or the pharmacy stationary than it is to be moving parts on both, I think. So that's how we just do it. Because we're processing so many, we have to make some assumptions, and that's the assumption. People would rather just stay with the pharmacy they're at now, unless it's like thousands of dollars difference, and it never turns out to be that way.
I think it was recommended to me by you that
Mhm.
I go to the Walgreens to keep the cost down as low as possible. And we didn't talk about CVS at all. I didn't even know that was an option.
Well, why don't we take that offline? I've got your, we can go over it, because there's, yeah, I mean, if we said, when we looked at it, Walgreens and this plan, then that was the best one for you.
Right.
Next year, we would look and say, unless you tell me you don't want to go to Walgreens, then stay with Walgreens, and now what's the best plan? If you said, I don't like Walgreens, I want to go to CVS now, okay, so now let's look at CVS and find the best plan. Now, end of the day, that number might be different than this total expense,
Right.
may not be all that much different, and it usually isn't all that much different, yeah. Okay?
What's the difference between a preferred drugstore and someone who's not?
Standard. So there's three types. There's out-of-network, standard, or preferred. Preferred have an agreement with the insurance company that somehow benefits the pharmacy and the insurance company. Doesn't benefit you, it's the same pharmacy, but somehow benefits them financially. So therefore, they designate it as a preferred pharmacy. In other words, they would like to steer the business that way. Standard means that in that insurance plan that they've got, it's not as financially beneficial to either to the store or to the insurance company. They would rather you not go there. However, it's not to say that the cost for going to a standard pharmacy are always going to be higher than the preferred. I see places where I look at plans, and because of this med or that med or this plan or that plan, whatever it is, there's so many factors to take into consideration, that this preferred pharmacy was more expensive than that standard pharmacy. Who knows?
Fill out the papers and see.
Yeah, I mean, I might recommend to you go to CVS, which in this plan is a standard pharmacy, but funny as it might be, the costs are lower than going to Walgreens, which was a preferred pharmacy. But once again, I wouldn't try and move that pharmacy if you want to be with it. I would rather look at just all the plans and find that.
Well, up until this past year, we traveled all the time. So it was to our convenience to have Walmart, because there's Walmarts in every state.
Yeah, yeah. Well, and that's a consideration. That comes up when we're looking at independent retail pharmacies local to the area. Being a pharmacist, I have a real passion for the business, and I love independently owned. My dad was a pharmacist, independent drugstore, and so I have a passion for supporting that business model. However, because they're not networked across the country, there will seldom, if ever, be a preferred pharmacy. There'll be a standard pharmacy or out of network entirely. Now, there's some other things, like one of the least expensive plans. The least expensive plan last year was one that had a premium of $7.20 a month. I think it's going to $7.40 a month. Great premium. And the coverage wasn't bad. It was a pretty good plan for a lot of people. But the stickler about this was Walgreens was out of network. So if you took that cheap, that inexpensive plan, as good as it is, and then you started going over to Walgreens, you're going to be paying list price for everything, and it's going to be ridiculous. So when we were advising people, we said, remember, do not go to Walgreens. And anybody that would submit their report last year says, I use Walgreens, I wouldn't even use this as an option for them. I'd go to the next option because, well, they want to go to Walgreens. I'm fine with that. We're not trying to steer business anyway. We're just trying to analyze the data and give you the unbiased recommendation of what your options are. Okay, sure.
I do not have a computer, and so I would have to go to the library to set up my Medicare.gov account. Should I be worried about security where I'm using a computer?
Wow, that's a great question. One I'm not qualified to answer, to tell you the truth. I don't have an answer, but for purposes of what we're doing here, you can certainly just fill out the information on the form, submit it to Laurel, and just write on there, I don't have a computer at home, and we'll take care of it. I mean, it's sort of when the reports come in without an email, we handle it differently by sending a hard copy and so forth. So the fact that you don't have a computer, there really isn't anything you need to do with that computer, because we're running the analysis for you. We're running and giving you a hard copy of the report, and then dropping it here for you to pick up. So we don't have to email it to you either.
So I would never have to access that account for any other reason?
You could if you want. You don't have to if you don't want. And I'm sure many people don't. The government's master plan is to eventually have everybody migrated over to this website so that they can communicate with Medicare beneficiaries, update all the information. And it's a good plan. I mean, it is what it is. But the fact is, with any plan, you're going to have certain population that are not on computers. They don't feel comfortable. They don't want to do it. I do everything for my mother-in-law. I mean, God bless, she's 91. She's like she's 60, but she does not want to do an email or anything like that. So she uses my email for all this stuff, and I just sort of triage it with her. So the fact that you don't have a computer, the fact that we don't have an answer for your security question would lead me to think that for this purpose, don't worry about it. Just deal with Laurel, and we'll take care of everything in hard copy. And you won't, you'll be able to call the 800 number to enroll in the plan if you're so inclined. You don't have to even go online for that. Okay?
So if I'm looking to switch an Advantage plan because I have a new primary care and my plan doesn't recognize this.
Okay,
primary
yeah.
care, do I need to do this?
No. You'll add to confusion. Instead, you should set up an appointment with Laurel for us to chat.
Okay.
Okay? And for that purpose, you want to bring a list of your meds with you. If you're not familiar with the differences between like the MedX plus a Part D plan versus your Advantage plan, we'll talk that through. And then we'll figure out what's important to you. And it's way easier to go from Advantage over to this way than it is to go from here over to an Advantage plan. Because, as I say, there are so many flavors on the Advantage plans that I mean, I've got spreadsheets, and this one's got a copay and that a copay here, and to find that one that matches what you need is impossible. But to say, all right, I got what's important, great, let's flip over here. It's much easier to go that way. Simplified. Okay?
I may have missed this because I did come in late. I haven't been on the Medicare Advantage plans that they're advertising, they make it sound like nothing will be taken out monthly, like we have now. And as far as I know, it's only going up $10 next year. But I find that that's very deceptive because they're paying a lot more. So that did a long time ago. Now maybe they've changed.
Yeah.
But I was trying to get something that would keep my costs down.
Yeah.
And instead, it inflated it.
Yeah, so the question is, so first off, if you're talking about not taking anything out, you mean the 148.50?
Right.
That's going to come out regardless of an Advantage plan or MedX.
Yeah, well, they made it sound like it wouldn't come out, and most of them do.
Yeah.
Jimmy, what's his name? What guy that was on? Oh, God.
Oh, I know what you mean. Yes, yeah.
He makes it sound.
The whole marketing, the whole marketing of Advantage plans is pathetic, quite honestly, and really not very truthful as far as I see. A lot of the things you hear them talking about, like you're going to get vision and you're going to, let's take the vision and hearing, for example. You're going to get vision and hearing, you're going to get dental. Okay, so dental, it's cleaning and x-ray once a year. If you have any real work, you're paying. The vision and hearing, it's an eye exam and then a credit towards glasses and then a hearing test and a credit towards hearing aids. Now, the hearing aid credit may be a good thing. I'm not sure how big it is, but I think that's reasonable. I know.
Depends on the plan, 'cause
Okay.
I've been working, I don't have hearing problems.
Yeah.
So my kids might say differently. And, that's because I'm trying to ignore them. And, but, I was calling around for my girlfriend had a tough plan, and you had to go with one vendor.
Yeah.
Number one.
Yeah.
And they did do, it was every 2 years you could get
Yeah.
replacements. It was like, okay, how do I explain
Yeah.
this to someone with dementia?
Yeah, so, when they talk about including on these Advantage Plan commercials, they include the vision and the hearing thing. As many of you may already do, when you get the Blue Cross or any of the other plans like the Sapphire or Core or Bronze, the rider is $2.50 a month to add vision and hearing. So, look, it's $25 a year, and right off the top, they're going to pay the eye exam and give you $150 towards glasses or contacts that year. So, as far as I'm concerned, the fact that the Advantage Plan is telling you that, they're telling you that, but you can do that. So you don't have to have that drive your decision. The other is like gym memberships. We give you a gym membership. Well, I get $150 back on my gym membership from Blue Cross every year. You just got to submit it. Yeah, so a lot of these Advantage Plan advantages aren't really any different, but it's like any other form of marketing. They're going to make it seem like it's a thing unless you know that it isn't. And, we can help you sort out fact from fiction. Personally, I think Advantage Plans are really good things for the relatively young, healthy individual that doesn't have a whole lot of health needs, doesn't need a lot of resources. Life is good. If you're getting up there, as we all are, and we get more and more health needs, I question whether that's really the best way to go, because then you find out your bills are off the wall. The Wall Street Journal had a report this past week was picking out your healthcare, and that was pretty much their conclusion. Exactly as I've been saying, how do you figure it out? Well, it depends on what your needs are, and don't think Advantage is going to make healthcare go away. So it said the same sort of thing. And it's a time check law. Were we supposed to be done at 2 or 2:30, or does it matter?
Whatever, when you're done.
It's okay?
Yeah.
Okay.
I have two friends that recently fell. One had an Advantage Plan and the other one had something different.
Yes.
The one with the Advantage Plan couldn't get into a rehab. They wouldn't accept her.
Yeah. Yeah, I mean, there's some things with advantages that are not an advantage.
And at our age,
Yeah.
everybody needs a rehab facility.
Yeah. I'm sorry, you've got your hand up the whole time. Go ahead.
I have two questions.
Sure.
As a pharmacist
Uh-huh.
with a long history in pharmacology,
Well, not that long.
but in working at one of our premier hospitals,
Uh-huh, yeah.
do you think that pharmaceutical companies, if a drug is in a certain tier,
Yeah.
if that drug gets more popular,
Mhm.
do they lower the tier? Have you ever seen that?
Yeah, no, the tier has more to do with, like, is it still patent protected?
Oh, I see.
When a drug becomes no longer patent protected, then it typically will drop into a lower tier because it's becoming a commodity. And like any commodity, there's no difference between, Lipitor was a brand name product and it was up tier 3, very expensive. Patent ran out, sold generically as a atorvastatin, dropped to tier 1, 0 copay. There's no difference between drugs and new improved Tide. When Tide is just, everybody's got Tide, and they say, well, we got to make more business here, we got to increase our market share. Now, all of a sudden, there's new improved Tide. It may not be new and improved, but they're creating a market for themselves, and then they can move and charge you more for it. Drugs have the same sort of life to them. Yeah.